Yes, I am.
Okay. Welcome, everybody. We have presenting today Darren Toh, who's an assistant professor and pharmacoepidemiologist at the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare. Dr. Toh has recently been focusing on three main activities: the evaluation of comparative safety and effectiveness of medical populations in large, diverse populations, application of causal inference methods to improve the alignment of observational and randomized studies, and the assessment of the safety of medications in pregnant women. Today, Dr. Toh will be talking about incomplete adherence. Incomplete adherence to health interventions is frequently observed, and this lack of adherence represents a challenge to comparative effectiveness researchers seeking to quantify the effect of an intervention. A range of analytic and study design options are available to researchers, but there is no clearly superior approach, and each of the available approaches involves trade-offs whose effects on the research may not immediately be apparent. Dr. Darren will describe some of these approaches, and with that, Darren, take it away.
Good, Jeremy. So this is a sound check. Just want to make sure that you can hear me okay. Hey.
Sounds good.
We can see the slides, and participants' lines are muted. They'll be unmuted at the end of Darren's presentation.
I see. I'm happy to be here today to talk about some methods that we could consider whenever we are interested in adjusting for treatment non-adherence in our studies. For the purpose of my presentation today, I'm just going to focus on medications, but these methods that we are going to talk about can be applied to other medical products as well. And I'm going to use a clinical trial as an example. Again, these methods can be applied to both mice and observation data. So let's go over the slide. So before we start to talk about the methods, let's just clear up some of the terminologies that we are going to use today. So there are at least two measures that we see in the literature that are trying to describe the treatment patterns of patients over time, and people sometimes use these terms interchangeably, but in fact they have different meanings. And the first measure is compliance or adherence. So basically, this is a measure that describes how well patients follow prescribers' instruction in terms of the timing, the dosage, and frequency of medication taking, and it's often represented as a proportion, like the medication processing ratio that we are more or less familiar with. And the measure is what we call persistence, and it's usually represented as a duration of time from treatment initiation to complete stopping of medication. So if you're taking any medication at all, even if you are not taking as instructed by the prescriber, you consider persistent until you completely stop your medication. And what we are interested in today is actually a combination of these two measures. So we want to know what the treatment effect would be if patients receive the treatments as instructed for as long as they need to. I'm sure in your own research, you often find it very challenging to know whether patients are taking their medication as instructed or whether they have stopped their medication. But for the purpose of this presentation, let's just assume for now that we have information on treatment adherence so that we can just focus on the methods. I'm going to use adherence, persistence, compliance interchangeably throughout the presentation. Hopefully that would not be too confusing. So reasons why we are interested in adjusting for non-adherence, I'm just listing some of them here. Sometimes the reasons for adherence can actually be addressed. For example, patients might stop the medication because of some side effects, but the side effect can actually be managed or alleviated. So in this case, we want patients to continue to take their medications because the reason for stopping the medication can actually be managed. Some it might be because of high co-payment. So it can also be addressed by, for example, reducing the co-payment or even giving drugs for free. So in this case, you will also be interested in seeing what the effect will be if the patient are continuously taking their medication. But some of the reasons are just too hard to tackle. For example, some severe side effects that forbid from taking their medication. Sometimes they just don't want to take a medication regardless of what they tell them. So in this case, the exercise might be more scientific rather than clinical. And you can also think of all other reasons why you want to adjust for treatment on adherence in your own research. And traditionally, we have been using some methods to try to get the effect that adjust for non-adherence. I'm listing two of the most commonly used ones. The first one, we shall call it the per protocol analysis. So this is a term borrowed from a randomized trial. Basically, the analysis only includes patients who are fully adherent to your assigned treatment. So for example, if you are interested in comparing drug A versus drug B under full adherence, you would find a subset of patients who are adherent to drug A and do the same for drug B, and then compare risk of outcomes. And we know that this might create some potential selection bias because patients who stick to them might be very different from those who stop their medication during follow-up, and the differences might be predictive of the outcome. So this method is easy to use, but it has some limitations. And second approach, and we shall call it the treated analysis. In analysis, you include all patients. Some patients take the drug for 1 month, some for 3, some for the entire follow-up. You don't censor patients when they become non-adherent. You include them, but in analysis, you need to some sort of dose response model to link the duration of therapy to the risk of outcome, or whatever you think that the functional relation would be. Maybe it is the dosage, maybe it's some other function of the intensity of treatment. Basically, in this analysis, you need to make an additional modeling assumption to include all patients in your analysis. And very often we will also suspect that there might be some time-dependent confounders that predict treatment non-adherence as well as the outcome. So we usually try to measure these confounders and then try to adjust for them in the analysis. And one of the most commonly used methods is the time-dependent Cox model. It has been shown that this traditional approach, we should call them, which include time-dependent Cox model or matching or stratification, they might be biased if time-dependent confounders that are also affected by prior treatments. And to see me here, let's look at this graph. So this is a very simple cyclic graph or deck. To simplify things, let's assume that we are interested in estimating the treatment effect under two treatment, complete treatment, and we shall use A0 and A1 to represent the treatment at each month. So you hope that the patient would take the drug in both months, and you are interested in the effect on this treatment adherence on the risk of your outcome, which is represented as Y here. And there is a set of variables that are summarized as U here. So U means that these variables might not be there, but if you measure C1 well, you can adjust for the effect of U. C1 is actually the guy that is going to give us the most trouble, and we're going to talk about it in a minute. It might be something that is on C0, which instead of covariates that are measured at baseline, but they don't actually change our discussion, so I'm just ignoring them in this graph. So we say that C1 has a complex relation with our treatment of interest, which is determined at both time points. So let's see what we mean by this. So if we get rid of the things that don't matter, and just focus on C1, A1, and Y, you will see that C1 is actually a confounder for the effect of A1 on Y because it is associated with both A1 and Y. So I hope the relation between C1 and A0. Again, let's get rid of things that don't matter. And C1 is what we will call an intermediate variable for the effect of A0 on Y, because at least part of the effect of A0 is through C1. So what do we learn from this? On one hand, we know if we want to get a best estimate of A1, we need to adjust for C1. Only if we look at A0, we sort of know that we cannot adjust for it because it is what we call intermediate variable. And of time, I'm just going to tell what we need to do here. We need to adjust for C1, but we cannot adjust for it using traditional approaches. Unfortunately, you have to take my word for it. And if you're interested, there are some references that you can go to see why this is the case. And traditional approaches, including the time-dependent Cox model, are not ideal because they will create additional biases. So see what I mean here. The traditional approaches are more a conditioning approach. If you put C1 into the regression model, you are conditioning on C1, and in the DAC term, we are going to use a box to mean conditioning. And also in the DAC term, we call C1 as a collider because the two arrows, they go into C1 and they collide at C1. So if you condition on a collider, you are actually creating a spurious association that will bias your result. So that's why traditional approaches might give us this estimate when there are time-dependent confounders that are also affected by prior treatment. So we have other ways to get the adherence-adjusted treatment effects. And what I hope we could agree on today, at least, is that estimating adherence-adjusted treatment effects is conceptually very similar to estimating time-dependent treatment effects. So the time-dependent treatments, it usually meets conditions. The first one is that the treatment is determined over multiple time points, and the second condition is that the treatment can change at each time point. And what is the treatment effect under full adherence? It is, when you think about it, it is a very special case of time-dependent treatment because it meets these two conditions. But in analysis, you are interested in the very special case of treatment pattern, which is that the treatment remained the same over the entire study period. If you were to draw DAC for time-dependent treatment, this is exactly what you would create. So the message here is that estimate the effect of treatment of full adherence is very similar to estimating a time-dependent treatment. And if you look at things from this perspective, now we can use the methods that we have been using to estimate time-dependent treatment effects to get the adherence-adjusted effects. There are a number of methods that we use to estimate time-dependent treatment effects, and we are going to focus on one of them today, which is the inverse probability weighting. Informally, the inverse probability weight, or the IP weight, for each patient is the inverse of the probability of receiving his actual observed treatment given his prior treatment and covariate histories. And the IW approach has been shown to be able to adjust for selection bias that arises from the per protocol analysis that includes only adherent patients of under certain assumptions. We are going to talk about the assumption at the end of this presentation. IPW has also been shown that to be able to adjust for time-dependent confounders that are also affected by prior treatments, commonly seen in the ScD analysis. Going to incorporate the IPW approach in the two analyses that we talk about. We are going to do a modified protocol analysis, and we are going to do a modified ScD analysis. To see how we can do that, I think that it would be good for us to go over an example. So the one that I used here is a randomized trial of antipsychotics. So this trial was designed to look at the comparative effectiveness of atypical and typical antipsychotics. It's an open-label, multi-center trial. Originally, it has 3 arms, so patients were randomized to receive olanzapine, risperidone, or typical antipsychotics. Typical antipsychotics, physicians actually had the flexibility of giving a specific agent to the patient. So within the typical antipsychotic arm, you might be receiving different agents. And for analysis, we are going to combine olanzapine and risperidone arm because they are both called atypical antipsychotics. And to simplify things, we are just going to deal with 2 arms. Set of eligibility criteria that I list here. So here's a baseline randomization visit, and 5 follow-up visits that took place at week 2, as well as months 2, 5, 8, and 12. And the outcome of interest is the change in psychiatric rating scales at month 12 compared to baseline. SRS, as some of you might know, is a pretty common measure to gauge the severity of schizophrenia. It comes with different versions, and in this trial, 18-item version was used. So each item has a score from 0 to 6, with 6 being the most severe. Because the outcome was measured at month 12, so by definition, only people who completed the 1-year follow-up visit will be included in the analysis, and that would create an additional complexity to the analysis because there might be potential selection bias due to loss to follow-up. And in our analysis, we also need to address this potential source of bias. So the baseline characteristics by treatment arm. So there's a typical antipsychotic arm and a typical or conventional antipsychotic arm. So you can see that the basic characteristics are pretty well balanced between the 2 arms, even though if this was not a large trial. And you can see that the mean BPR score at baseline was pretty comparable between the 2 arms. So loss to follow-up and treatment non-adherence were pretty severe in this trial. So by the end of the study, just over half of the patients in the typical antipsychotic arm completed the follow-up, and the proportion is 61% in the other arm. And in treatment non-adherence, the number is even more miserable. So less than half of the patients randomized to the typical antipsychotic arm had a complete follow-up plus complete adherence to the assigned treatment. This proportion was just over 1/4 in the other treatment arm. We will know what the effect will be if we appropriately adjust for treatment non-adherence. So we do analysis. The first one is the modified per protocol analysis. So like the traditional per protocol analysis, we are only including patients who are adherent to the assigned treatment and had complete follow-up in the outcome analysis. We use IPW to adjust for potential selection bias. So in this analysis, we will censor patients when they were lost to follow-up or when they became non-adherent to their assigned treatment. And we then use IPW to adjust for these two sources of censoring. So the first one, we are going to go over this now, is censoring by loss to follow-up. So with IPW, so I apologize for this filler, but let's focus on the denominator here. So what we did here is that at each follow-up time, we estimate patient's probability of remaining uncensored, given that they have not been censored before and given their prior treatment and comorbid histories. And we did this for all follow-up time points, and we fit the model separately for each treatment arm. And each visit would give us an estimated probability of remaining uncensored for each patient, and then we just multiply them to get the overall probability of remaining uncensored at the end of follow-up. In theory, we don't have to do anything with the numerator, but you see that we also fit this model in the numerator because they actually stabilize the weight a little bit so that we can get a narrow 95% confidence interval. And we did more or less the same thing to adjust for censoring due to treatment non-adherence. So you can see that the two models are pretty similar, so I'm not going to go into detail with this treatment model. So at the end of this process, each patient will have an estimated probability of remaining uncensored and an estimated probability of remaining on their assigned treatment. And we use these two probabilities and then get a product of these two weights to get overall weight for the patient. So what this process is doing is trying to re-weight patient. For example, let's say that a patient had a probability of 0.2 for remaining in the study and being fully adherent to his assigned treatment. And if you take the inverse of 0.2, you get a weight of 5. So this means is that in your analysis, this patient would be representing himself for additional people who had similar characteristics to that patient, but were censored because they were either lost to follow-up or became non-adherent. So using the for that patient to get the outcome information for 4 additional patients under assumptions that we are going to talk about at the end of this presentation. So after you get the weight, you feed it a weighted outcome model, and in this analysis, we feed it a weighted least square model. It depends on what your outcome is. If it is a binary outcome, you will feed the logistic regression model. And because the weighting process introduces correlations between the observations, so we usually use a robust variance estimator to get a more conservative 95% confidence interval. You can also use bootstrapping to get a slightly narrower 95% confidence interval. So that was the first adherent adjusted analysis. Now we are going to talk about the second one, which is the modified as-treated analysis. So like the traditional as-treated analysis, we don't throw out patients when they became non-adherent. So by doing this, we will be able to include more patients in our outcome analysis. But to pay a price by having to assume additional dose response model that we discussed previously. So we went through the same process of creating a way to adjust for loss to follow-up, because this analysis still requires that patients to have a 1-year complete follow-up to be analyzed. And we also feed another weight model that basically models the observed treatment history, and then we weight patient by this estimated probability, by the inverse of this probability. In doing that, we adjust for time variant confounders that might be affected by prior treatment. And in outcome analysis, we had to assume a dose-response model. For this analysis, we assumed that the changes in the BR score at month 12 from baseline have a linear relationship with the days of treatment. This is a modeling assumption that we made. It might or might not make sense. So in your own research, if you have a priori hypothesis, you would fit your outcome model accordingly. In your research you are not sure about the relationship, maybe you want to fit the models to see how robust your results are to these additional modeling assumptions. Just some final notes on the weight estimations. Because weight is changing over time, so are the time-dependent confounders. Usually in our analysis, we transform the data into a person-time data structure. In analysis, we are dealing with person visits, so that's how we structure our data. And if you have this type of data structure, you can use pool logistic regression models to approximate Cox models, and that's what we did here. And we usually fit the weight model separately for each treatment arms, so that the same variance can have different effect on different treatment arms. And if you have more than one sensory mechanism, like what we did in our analysis, you also fit the model separately for each sensory mechanism. So we fit the model separately for censoring due to loss to follow-up and due to treatment non-adherence. As we discussed before, the weight can be stabilized to get a 95% confidence intervals. This approach can be extended to studies that use different measure for non-adherence or treatment status. So we've also used method to deal with the scenario where treatment was represented as a proportion, like the medication processing ratio. For this study, we also perform a series of intention-to-treat analysis so that we can compare our adherence-adjusted estimate with the intention-to-treat estimates. So we did 3 intention-to-treat analysis. The first one is what we call a last observation carry-forward approach. So this ability gives you the largest sample size in your outcome analysis. Because it would just carry forward the last measure BPR score. So let's say that you only have the measure taken in month 2, the analysis is going to assume that that measure would be your month 12 measure as well. This is a huge assumption, but it would include more patients. And it's not uncommon for us to see this approach being used in randomized trial. I also did an intention analysis that include only patients who had complete one follow-up, and we discussed that this might introduce selection bias, so we also use IPW to adjust for this potential selection bias. These 2 tables are just to show that many of the baseline and time-dependent confounders are pretty predictive of treatment loss to follow-up and treatment discontinuations. And for some of these time-dependent confounders, we also have reasons to believe that they might be affected by prior treatments. So support the use of the IPW approach instead of the more traditional methods. Is a of the results. So let's just focus on the ones in the red box here. So in the study, we also use another method that can adjust for non-adherence. So this is the G estimation approach, but we don't have time to go over this. If you are interested, you can go to the paper and see how we use this method to adjust for non-adherence. It requires another set of assumptions that is somewhat different from the IPW approach. So talk about the 3 intention-to-treat analysis. So the first one is the pseudo-ITT analysis. My apologies for the very bad naming system we have here. But this is basically the last observation carry forward approach. As you can see, it allows you to include more in your outcome model compared to other approaches. So point estimate from this analysis is negative 1.5, which means that the reduction in the BR score at month 12 from baseline is more in the typical antipsychotic arms compared to the typical antipsychotic arm. This was not a very large trial, so the 95% confidence intervals for all the analyses are quite and somewhat overlapping. So the second ITT analysis is the unweighted complete case analysis. The estimate is 0.42, which is quite different from the same analysis that further adjusted for selection bias due to loss to follow-up. If you believe that all the other analyses give you more value estimate, the result will indicate that there is indeed a selection bias, and we sort of need to adjust for it. So two adherence adjustment analysis. So the first analysis, which is the modified protocol analysis, gives us the lowest number of patients in the outcome analysis because it requires patients to be fully adherent to the assigned treatment and had a 1-year complete follow-up. The point estimate is negative 1.5, which is somewhat different from the other adherence adjusted analysis, which had a point estimate of negative 0.5. So a number of reasons why these two adherence adjusted analyses give us different results. The first one that you can think of is that maybe the dose response model was not entirely accurate in this analysis, or maybe that the model that is trying to adjust for selection due to treatment non-adherence might not be entirely correct in the other analysis, or it could be due to change, or it could be due to other reasons. Let's talk about the assumptions that we made along the way when we are using RW to adjust for treatment non-adherence. So the first one, which is the one that we made up front, is that treatment status is measured accurately at all time points. This is perhaps the most important assumption that we have to make. Sometimes it's challenging for us to know for sure in our database, especially if we are dealing with electronic healthcare databases. Sometimes the granularity of information might not be too good for us to determine when patients stop their medication or when patients initiate other medications. And we'll need to have all the information on the time-dependent confounders as well as the baseline confounders. Again, this is assumption that we sometimes have to make in our analysis. And we need a correct model for the weight, and if you are using the modified analysis, you also need to have a correct weight model. And the assumption is what we call the positivity assumption, which is also known as the experimental treatment assumption. Basically, what this means is that for each combination of your covariate history, you need to have in each of the treatment groups that you are looking at. Sometimes violation of positivity might be due to chance if you stratify your data too finely. Sometimes it's the real violation of positivity. Maybe patients develop some contraindication during follow-up, which would put them only in one type of treatment. So that would be a violation of positivity. So in our research, we need to be very careful and to determine whether the violation is due to chance or whether it's more mechanical. So there are a number of methods that we can use to adjust for treatment non-adherence. Some provide bias estimates when there are selection bias or when there are time-dependent confounders that are also affected by prior treatments. And there are other methods like the inverse probability weighting that appropriately adjust for this type of time-dependent confounders and have shown to provide more valid estimate under generally weaker assumptions. Our own research, we just need to be mindful about all the assumptions that we make and choose the method that require the weakest assumptions. And I don't want to sound too cliche, but whenever we're not sure, it's always good to try different methods and to see how robust our results are to these different assumptions. And I think I'm just going to stop here, and we have plenty of time for questions and comments. Thank you.
Thank you much, Darren, for that very engaging presentation. I'm going to open up the floor for questions right now. Liz is going to unmute everyone's lines so that questions can be asked. We will request, however, that if you're not currently asking a question, please keep your own line muted so we can minimize background noise on the call. So the way to ask questions, of course, is to enter them into the Q&A window on your WebEx. And we have a question awaiting there. It's from Chris Rowan. He asks you, Darren, if you're reweighting at each time point, which were the 5, 8, and 12 months.
Sure, I say yes. So think of this in two ways. Estimate. You can think of it as a cumulative probability of remaining uncensored at each month. So, for example, let's say that you are in number 5. So we estimate probability of remaining uncensored at month 2 and month 5 separately, and then try to get. Or you can just think of it as a cumulative. So again, everything is conditioned on the past. So if we're talking about month 5, we are talking about the cumulative probability of remaining uncensored through that month.
Thanks, Darren.
Other questions? On the line or enter them into the Q&A box. While they're gathering their thoughts, Darren, I had a couple of questions myself. First of all, whenever I see weighted stuff, the first two questions that come to my mind are the positivity assumption, as you mentioned, and also the risk of upweighting or downweighting various cells that may or may not deserve to be upweighted or downweighted. Can you talk a little bit about first positivity assumption and maybe interpret it a little bit, sort of what that would mean in this study? How you verify that there's positivity, and what it would mean if there were a relation of positivity. And then I'd like to follow after that with some questions about who was weighted up and weighted down.
So I would try to give positivity in two ways. So if we are talking about positivity at baseline, I think that is more straightforward. We could just, so it makes sense to create some sort of clinical equipoise to do any type of research. So if we're running a study, you know that positivity assumption will be validated because some patient might have some contraindication. They will put them only in one type of treatment. You will definitely not include this patient in your analysis. So when you are designing a study, baseline, I think it's easier to look at violation of positivity. People have done this through different ways, like doing propensity score matching, and then try to get rid of the tails, for example, and deal with violation of positivity at the baseline. So things get.
Can I know what a violation of positivity at baseline would look like? What would you see?
Okay. In a straight, there's no patient in a particular treatment group, so there will be a violation of positivity. For example, if you have a condition, they will only put you in one type of treatment, and if anybody who has this condition even this type of treatment, then by definition, you won't be able to compare two treatments within subgroup. In this case, you might think about you're asking a clinically meaningful question if you want to include these patients. So in this, you probably don't want to include them because in clinical practice, this patient would not be given any treatment. One hand, there is no way for you to study this. On the other hand, there's no point for studying this. When talking about relation of positivity in the time-dependent setting, I think that the general rule applies. You would just look at your data by specific strata over time. So unfortunately, it's hard for us to make any recommendation on how finely you want to look at your data. Many of the times, you need to use your own clinical epi judgment to see if there is any violation. There's a nice paper written by Cole and colleagues that actually talk about how you can go about examining potential violation of positivity. I think it's published in AJE last year. So there are some ways that you can do it. And one way to get around the issue of positivity is to do a dynamic treatment regimen. I don't want to get technical here, but by dynamic treatment regimens, I mean that the treatment evolves as the prognosis or indication of change over time. So if patient develops something that will disqualify them from a particular analysis, you can actually use this more advanced approach to deal with this type of situation. So there are ways for us to get around this. Some of them are easy, some of them are more challenging. Let's stop here.
Can I ask one more thing? Is when you're modeling the weights, does that mask relations of positivity in the model that you would see if you were doing it by hand, or is it?
So it actually shows up. If you have some very extreme weights, then you need to start thinking about whether there is a violation of positivity. For example, if you have a very extremely large weight, then you might want to look at that further. Look at this patient further and see if they have any particular covariate and treatment patterns that would lead you to suspect that there might be some violation of positivity. So ways are a good indicator for this type of things.
Questions from the line, and then we also have another question queued here from Chris Rowan in the Q&A window.
Yeah, can you hear me, Jeremy?
Chris, yes.
Yeah. Hi, Darren. Yeah. First of all, thanks so much for your excellent talk. You always do such a nice job of taking complex subjects and making them easy to understand and very interpretable. So thanks a lot. I really enjoyed the talk. Darren, a couple of questions for you. So I love the idea of for time-dependent confounding or variables. And the example that you gave was in the setting of a clinical trial where you have consistent follow-up endpoints for all of the members and all the subjects included in the study. I think is a more reasonable format for reweighting. It gives you specific time points to reweight. In an observational study, where you have sort of fixed time points to reweight, where COVID is changing, at inconsistent intervals. Do you have a sense of how you might be able to up this method to the observational study
Mm-hmm.
We don't have consistent follow-up time points that guide you on where you reweight the data.
Mm-hmm. So that is a great point, Chris. Number of ways to this situation. If for specific topics, if patient go back to see the physician on a regular basis, then that would simplify things a lot. For example, I don't know too much about all the clinical areas, but maybe there are some type of treatment regimens that will require patient to go back, for example, every 2 weeks or every month. So in this case, it's easier for you to set up your analysis. Of course, there will be patients that would not go back as scheduled. This also happened with randomized trial, but at least you have some sort of a guidance on how you will set up your analysis. And this is not the case. You just need to make up some sort of rule. You can do it by month. Try to create an artificial time points, like every month you are going to follow patient. You're going to structure your data into a person month structure. So you would just do what we just described. And sometimes it might just be easier to do it at the denominator, which is day. So person, I think, is the most refined way that you can do this type of analysis. So if that works for some type of analysis, I think that it can also be considered. So I hope that this answers your questions. And I know that this method has been applied to observational data.
Yeah, I like the idea of I agree with you completely. I like the idea of reweighting by day. I guess the issue really depends on how large your data set is and how many patients are in your study. Because you can imagine if you started reweighting every day, your population get very large, which means your data set could get enormous, which might pose some analytic challenges.
And not only analytical challenge, but whether it makes sense or not, because in theory, of course, patient can go to the physician on a daily basis. If this is the case, then yes. But another question is how well can you estimate potential time-dependent confounders where they can be measured in some refined way is another issue, and a lot of assumptions have to be made when we are dealing with observational data, and I think that it will make sense in some cases to do a person day data structure, but we are making some assumptions by that approach over other approach, like for example person week or person month. So I don't need recommendation to which is better, but it's that we need to make up some sort of rule in our analysis.
Yeah, thank you, Darren. And that's an excellent response, and I appreciate that. One last question, then I'll stop talking. So your paper, you present the different results, and but which one's right? And I was just wondering if maybe you've done simulations where you know what the right answer is, and you can use these different methods to see which ones come closest to the correct answer.
This is a great point. But look at this from a different perspective. There is always a primary analysis in any randomized trial, so including this one. And people think that would give you more truth because randomized trial is considered gold standard. So if we were to choose the ITT analysis, you can choose one you like. The ITT analysis would give you the true estimate. But as we saw in this analysis, they're making assumption as well. Even in clinical trial, we are making some assumptions when we use the ITT analysis. And it's hard to know which one is right, which one is wrong, because, for example, the ScD analysis is estimating a different treatment effect than the ITT analysis. We are talking about different treatment effects. Technically, they are not directly comparable. We show it to just to know that first, there are different treatment effects, and second is that what happens if you try to adjust for non-adherence. And within the adherence adjusted analysis, you are that we don't know which one is more accurate. Sometimes it just comes to which assumption you believe more. If you believe that the dose response model is more accurate than the weight model that is trying to adjust for selection bias due to non-adherence, to go with the modified ScD approach. So it's, in the perfect world, you hope that they will give you the results. But in the less ideal world, hopefully by doing this different analysis, you will be able to know more about your analysis and see which assumption is weaker, which assumption is stronger, and just have to be mindful about all these assumptions.
Thank you so much, Darren.
For the questions. Anyone have questions for Darren?
Darren, it's Alan Ellis. It's a nice extension of the marginal structural models. So I appreciate that. Thanks for doing the talk. One question I had is if you would say a little bit more about the dose response assumption that's involved.
Something that I didn't mention is that this dose response model analysis is not that perfect because we actually merge two things, which is the recency of treatment and the duration of treatment. So what I mean is that let's say that you are interested in the treatment effect under the patient are being treated for 6 months. So you can get 6 months in different ways. So it can be treated for the first 6 months or the last 6 months. So even what we are interested in here is to look at the treatment under 1 year. But I hope that you know what I mean. The dose response model actually by these two things. So we cannot differentiate recency from duration of treatment in some circumstances. That's one thing. Another thing is that it's a modeling assumption. Sometimes you just don't know which you are making the right assumption. In our analysis, we assume a linear function between the days of treatment and the changes in the BPI score. If you ask a psychiatrist, he or she might tell you that this might not make sense. So the response model is hard to come up with, and whenever you come up with one, you almost don't know whether you have it correctly. So I won't be able to know where we are making the right modeling assumption. We actually try different modeling assumptions, and the result actually change based on the different assumptions. So the new is that there was the methods of project, so the result themselves are not the most important things. And the bottom is because the sample size was so low, so everything at 95 confidence interval is overlapping with the one, so we cannot make too much of it even if we wanted to. So that's all I have to say about the dose response model that we used and the analysis in general.
I think we have time for one more question. I had one question, which was you mentioned just as a bullet point you did the variance estimation, and I'm trying to find where that was in the slides. Can you talk a little about how you you get variance here? How you calculated that?
So if I remember correctly, we just use a GE approach to get a robust variance estimator. We did do bootstrapping in this analysis, but we did that in another study. So I think that if you let me choose, I will go for bootstrapping. First, because it gives you a narrow 95% confidence interval, and second, if I remember correctly, it just makes more sense. The robust variance estimator is easy to get, but too conservative.
Is bootstrapping something like this, is that just logistically speaking an enormous undertaking? Are you talking about days and days of computing, or does it run relatively quickly?
Every time. This was done back in the day when I was a student with a very bad PC, so it took some time to run it. But now I think that we are talking about days. I think that we might be talking about hours to run one particular analysis. If you want to run multiple models, if you are, for example, if you have multiple small models that you are trying to look at, it might take more than that. So I have to be fair, for trial, we are not doing bootstrapping, but if we were to do it, it's not going to take too much time because we have a very low number of participants. But with technology nowadays, I don't think we are talking about days, even though I've encountered some situation where it took 2 days to run the analysis.
Thank you. If there are no more questions, I'd like to thank our speaker, Dr. Darren Toh, for a really interesting, very engaging presentation on a topic that is really crucial to the research that we do. So thank you, Darren, for your presentation this afternoon, and thank you, everyone, for attending this webinar.